Fair enough.
Hello, I think we're live. Great. Hello, welcome to our June Town Hall. We're gonna just crack straight on. Obviously we missed last month, so we got quite a lot to cover this month. But hopefully there's quite a lot of fun stuff in here as well. So it should be quite a nice Town Hall. Awesome. Let me know if anyone can't access the link or whatever. If you can't see the slides, just drop a comment in the Q&A. It's the same as always. We're live right now, but obviously we're going to put a YouTube, a version up on YouTube afterwards. But obviously it's better if people can join live. If there's anyone in the surgery who you know is intending to join, please go and nudge them, because it's good for everyone to join live so that we can have a discussion and make sure everyone is on the same page. Awesome. Cool. So a bit of a condensed agenda today. We're going to go through some updates on operations. Then we got some patient feedback with Julie. And then I'll go through some of the social stuff, some of the more fun stuff that's happening, for a little wrap up with a general update. Okay. So we're going to start with a very brief overview of COVID. I promised last time that we're going to reduce COVID to a minimum, so this is like the bare minimum. I think we got 2 slides. So basically, nationally, obviously we're at a very high level, 44 million, which is a ridiculous amount of coverage, and actually sort of 3/4 of those have already had their second dose. So that's really amazing, and hopefully we'll come back to normality. In terms of the vaccination supply, it seems to still be AstraZeneca and Pfizer locally, no Moderna, but obviously now all over 18s are eligible, subject to that availability for Pfizer. And really, it's actually a mix of second doses and first doses. I think it just depends on who's attending. In terms of us and the vaccination, so just another reminder: if you do want a vaccine and you haven't had one yet, just liaise with your reception manager. Please also let Teresa know, just so that we can log it on our end. It's obviously going to be very useful if you want to go traveling, if you're going to be going away anywhere. And I will note that it's apparently going to be mandatory for care home staff very soon. We're not a care home, obviously, but that's just an indication of how seriously the government is taking it. And I think, I wouldn't be surprised if they made it mandatory for all healthcare staff. At the moment, that's not what they're saying, but it's just something to bear in mind. I think it is worth getting, and obviously in terms of traveling, it's going to be vital. So if anyone wants to go on holiday, that's important. So yeah, let your reception lead know, and also let Teresa know. In terms of the vaccinating, we've got 21 non-clinical vaccinators now on our bank. So they have been doing a lot of heavy lifting, not just for us, but also locally at our hubs. They've been really filling in the gaps there. So up to July, so bearing in mind that they started in April, they will have done over 1,200 hours and over 240 shifts vaccinating, which is pretty amazing. I don't know how many vaccines that equates to, but if they're giving them at any sort of pace, it'll be a lot of vaccines. So that's really amazing, and obviously has saved us a lot of time. Which brings me on to the next point around workload, which has come back with a bit of a vengeance. Obviously, I think it's been very busy across the group for everyone, and I think broadly the recall program and the vaccination seems to be sustainable. At the moment, there's not a huge amount of extra workload. We haven't put a lot of emphasis on recalls recently, just because it's not. I think a lot of the younger cohorts are quite comfortable getting the text and just going in, so it seems okay. in that sense. In terms of if you're a clinician and you want to do some shifts, or if you're a receptionist and you're trained, yeah, let Alex know. We are still doing shifts, so if you're keen to do a shift, let him know. But otherwise, obviously, our non-clinical vaccinators doing the heavy lifting. And that's it for COVID. I've just put one graph in here because I quite like this graph. I thought it was quite interesting. I think this is a neat. Well, I haven't seen this graph before. It's on the gov.uk dashboard, but it just shows the kind of 7-day. Well, I think that the most interesting one is the 7-day average for vaccines. So you can see it went up quite a lot in middle of March, which stacks up with I think our experience. But it's basically reached a bit of a kind of natural level, and actually they're starting to fall in recent days. I don't know if it means anything, but you know, I find it interesting. It's all this sort of data is really interesting, and it tells us, I guess, a lot about the vaccine program and about uptake. So other operational stuff that is not COVID. If there are any questions, obviously let me know. I've just had a comment in the Q&A, which is really good, from Rachel, who says that apparently if any healthcare professional visits a care home, you'll have to be vaccinated. So that could be GP, nurse, paramedic. If you're going to be visiting a care home, bear in mind that you will need to be vaccinated. So I would recommend, if you haven't had one, please going and getting one. Otherwise, it could make things difficult. I'm not 100% sure when that's coming in, when that rule is coming in, but it'll be fairly soon, I imagine. So yeah, just re-emphasizing that point. So that's COVID. I promised it would be very short. Information governance, really important topic. It's obviously not the most exciting topic. I know that no one likes to do their information governance training or to hear about information governance necessarily, but it is really, really critical. And I think it's been highlighted very recently for a couple of reasons. One is obviously this data opt-out that was in the news quite a lot over the last couple of weeks, and lots of patients saying, you know, why are you sharing my data, etc., etc. So that, I think, has highlighted it. And obviously the second thing is we've had a couple of complaints and bits of feedback from patients where data has played an important aspect of those complaints, or it has been an area of concern. So I think, again, it's really highlighted for us, and it all culminates quite nicely because actually the DSPT, the Data Security and Privacy Toolkit, I think it is, right? Privacy, yes, which is the NHS sort of affirmation, effectively, that we are doing the right thing with regard to data and information governance. Is the deadline is tomorrow. It was extended. It's normally 31st March, but it was extended to end of July. So Greg and I have been spending a lot of time going through, mainly Greg, but we've been spending a lot of time going through that toolkit with a new level of rigor, I think, that we've never done before, and really trying to make sure that all our policies, all our frameworks, all our notices, all completely up to date. You're going to see in the next few days. I mean, so we're going to obviously the DSPT we have to submit, now ASAP, but it's an ongoing process, and I think we're really in the middle of it. So even though we'll submit the DSPT, there will still be changes. So you might see that the data and privacy section of the website is going to be updated quite dramatically. We're going to really try and simplify it and make it really clear for patients, where often these things are not as clear as they could be. So that's something that's really important to me, and I think will be important for our patients. In terms of what you guys need to be doing is please make sure you've done your online Bluestream training. We need that to be completed. I mean, generally across the board, Bluestream, we need it to be completed and up to date, and we will be doing more chasing and following up on that if it's not done. But information governance in particular at the moment, please make sure it's done. And we've then got a training which is coming up with Claire Clements. So she's our DPO. In fact, she's the DPO for the whole of Southeast London and possibly wider than that. She's a really, really experienced lady. She's very knowledgeable and actually very friendly and interesting as well. So she's going to be doing a training on the 28th of July at 1 p.m. Hopefully you've seen the invite from Julie about that. Please attend that as well. I'd highly recommend that. Her trainings are actually really good. Greg and I have attended 2 or 3 so far already, and they're really, really good trainings, and will give you a very high level overview, and also kind of give you the opportunity to ask questions or discuss any aspects that you're unsure about. And then in terms of our policies and frameworks, so I mentioned that we're updating a lot of those, making sure that they are really fit for purpose and really clear. Guidelines have changed a lot over the last couple of years with EU GDPR, and then now UK GDPR, Data Protection Act 2018. DSPT has changed quite a lot this year. So there's lots of bits that have changed. So please have a look at those. We're going to try and start sharing all of that through our SharePoint, which is a new thing which is coming. I haven't talked about it much in this presentation because we haven't really built it out much, but essentially we're planning to move over to an online shared drive, sharing all of the same resources. So you'll be able to look at it in there, and we're trying to sort of move away from those old shared drives which sometimes get quite out of date. But in terms of the policies, we'll share them with you when they're done. In terms of data opt-outs, I know that was an area that has come up a lot in the last couple of weeks. We have created a new page, so if I'm wondering if it might be worth going to the website very quickly. So if we go to let's say the Kingfisher website, which I think has still got a page. So if you go right down to the bottom, you'll see here it says GDPR and opting out, but GPDPR, sorry. So just as a primer for everyone, GPDPR is not the same as GDPR. I don't know who named this, and I don't know why they chose to use an acronym that is incredibly close to GDPR, but it's something quite different. It is general practice data for planning and research. So that's kind of what all the fuss has been about. It's what all the news has been about. Essentially, what has happened is that the old GP extraction service, the GPES, has been updated and modernized and is now called the GPDPR. Now, from a patient's point of view, obviously that has caused a lot of concern. But from our point of view, this is really not a new service. This is something that's happened for a number of years already, where NHS Digital need the data to kind of plan and do research on. And it's anonymized data or depersonalized data, and it's quite important for planning, the overall service within the NHS. This page kind of summarizes that here. And then if you look underneath, and we've put the little video there, which I think is actually really nice. It's like a minute or something, so it's worth watching. And we've put links. NHS Digital's page and South East London CCG's page are both really good. So worth having a read of those if you're interested. But then this is kind of the key bit about opt-out. So again, we've really tried to simplify it. You'll see this is going to move into our new page, but overall the content will remain the same. So I'm just going to take you through it briefly. There are 2 types of opt-out. So for anyone who hasn't read this or was unsure, from what we understand, there are 2 types of opt-out. Essentially, if you consider that we hold the data and NHS Digital need that data for planning and research, and they share it with let's say research organizations or whoever, there are 2 types of sharing. So there's sharing from us to NHS Digital, and then there's sharing from NHS Digital onwards to other organizations. Now, that's why there are 2 types of opt-out, because the type 1 opt-out is so that we as a GP practice don't share the data to NHS Digital or other NHS organizations. And then the national data opt-out is for NHS Digital so that they don't share the data with other organizations. Now, that is it. I mean, it's not really any more complicated than that. If we want to register a type 1 opt-out on our system, i.e. to stop us from sharing the data with NHS Digital, and when I say sharing, I mean, it's not like we're sending them an email with all this data. They extract it from EMIS at source. So it's really kind of a thing that just happens in the background. But in order to stop that, ideally we get that form from the patient, the one that's here. and just upload it to their record. And then if you see on the form, it actually tells you at the bottom which code to use. So if you put that code on the patient's records, that is it. That registers the type 1 opt-out. And it's no more complicated than that. If patients are really struggling with the form, or if they email or something like that, then I think that's fine. But the key thing is to just get that code on the record. And then in terms of national data opt-out, so that stops us from sharing the data, or from NHS Digital from taking the data from us. In terms of the data going from NHS Digital further, that is via this form here. So if you click on that link there, it takes you to the NHS Digital page, and you go to make your choice at the bottom. You can start, and basically it'll take you through a form saying, you know, you can check your details, etc., and then it opts you out. So that's it. And you know, obviously this is kind of, I realize it's at the forefront for a lot of patients, and I think there's a lot of concern about it. From my perspective, and I know that as an organization, we use a lot of the data for understanding the service, and I think that it's really important to be able to understand the service. We're not, you know, looking in people's records just so that we can, you know, have a snoop around, and I'm fairly confident that NHS Digital are not doing the same. I mean, they're taking depersonalized data, so from that point of view, they shouldn't be able to really identify the patients. But so I think really, ideally, we would prefer that patients don't opt out of the data sharing, but obviously it's completely within their rights, and that is the best place to send them. And if you do need to explain it to them, you know, please make sure you've read this. And I would highly recommend attending the training with Claire Clements. Like I said, I think she may well go through something similar, so it's worth having a look. Yeah, I think that's it on this page. Perfect. Okay. So very brief update on Mornington surgery. So as of yesterday morning, the Mornington EMIS is now merged with the Kingfisher EMIS. So effectively that is done. We're in a slightly weird transition period, because from the first, like from now until Thursday, so Monday, Tuesday, Wednesday, patients will still be going to Mornington surgery, but their data will be with our EMIS here, so their staff have got logins and stuff like that. But from the 1st of July onwards, those patients will actually start coming here, the staff will be coming here, and I just kind of wanted to let everyone, make sure everyone's aware of that. We've done a briefing for the Kingfisher staff here. Hopefully most people were able to attend that. If you weren't, then I think there's a link on the Kingfisher Teams. And yeah, I mean, really, it's going to be tough. Everyone's going to have to adjust in terms of staff and patients. So please be patient, please be helpful with both staff and patients. We made a little briefing pack. So if you click on this link, I mean, I can actually probably go back to the website and you can see it's really hopefully quite obvious. So if you go to Mornington Surgery Merger on the Kingfisher page, so we put some overview FAQs down there and a little briefing up here. So that's what that button takes you to. And then this is the new patient info pack. So it's just a little, it's like, it's 4 pages. It does get a little bit long, but we've tried to cover everything in here. So just kind of welcoming patients, giving them a bit of background, and then answering some of the questions that we've had come up quite regularly, you know, ad hoc and during the engagement. So that's really useful. I'd highly recommend you all have a look at that. Just skim through it. I know there's a lot going on. Just skim through it and read the bits that you think are most important. But it's generally, we're not going to share it with all the patients at the moment, I don't think. I think the plan is to have it in the back pocket. You know, if you need to send it to a patient, or if Julie needs to send it to a patient, then it's there. And obviously, you know, anyone who goes on our website can see it as well. I might also liaise with the old practice manager, Darshika, from Mornington Surgery, and see if there are any patients she thinks will benefit from that pack. But for the most part, we wanted to make sure that we've got it, so that if we need to send it, we can. And then in terms of yeah, the broader group, please just be patient with us, with the staff, and you know, there's a lot going on there, and it's really good that we've got all these patients, but the next couple of weeks I think are going to be interesting. And in terms of space, obviously we're now kind of reaching a capacity. We are looking into space alternatives, not specifically here, but across the group. I know we're really tight on space. So please just bear with us. We are trying to find a solution. Okay, that's what I want to say on Mornington. In terms of other little bits, so I've made this slide. Gurren can't be with us at the moment. Hopefully we will find out more about why soon. Hoping it's good. But in terms of notes access, we've basically the plan is to give. I don't know if people are aware of this, but there are different levels of access that we can give patients to their records. I think at the moment we've given them the summary record. We've always been concerned about kind of what might be written in the record and patients getting upset, etc., etc. I think in terms of what we want to do going forward is we want to really change that now to giving patients access to the full record, which is very much in line with the national guidance. We've been asked by quite a lot of people to change that. And I think it's also going to help us really reduce the workload, certainly for the clinical admin team who at the moment get a lot of medical record requests, and this will effectively remove all of those and simplify all of that. The other part of this is obviously that I don't know if you guys have seen, but the NHS app is really accelerating quite significantly at the moment. The uptake has been huge just because of the COVID vaccination passports. So it's a good opportunity to really lean into that and say, hey, it's worth getting the NHS app. It's worth doing these things, and then you've got your vaccine passport and you've got your medical record. Trying to get our patients online as much as we can. We'll talk more about that if we're going to do a bit more of a publicity campaign on that, but at the moment we're just kind of passively just helping with that. In terms of making sure that the notes online are okay, obviously I think it's just a case of remaining cognizant that what you write in the patient notes can always be requested. It has always been able to be requested by patients, and so we want to make sure we're being professional, we're being factual wherever we can, so that we don't end up in a sticky situation. And obviously we know that this is quite a big change, so we're going to try and switch it on in a bit of a phased way. So it's effectively the idea is to phase it, but hopefully have it switched on by October sometime, subject to kind of making sure that all works well. And then there are some other operational bits and bobs that Gurren wanted me to mention. So I think travel vaccinations are coming back really strong. People are, starting to go on holiday. There is obviously that form online, surgery name, so Kingfisher Medical Centre or Penrose surgery.nhs.uk/travel, and then they can fill that form in and it should come into the generic mailbox. I think Greg can also tweak who that comes to, so if you let us know, we can send that to the right people if that's helpful. So that's really important. Vaccination passport, I think I just touched on. So the NHS app, I've actually got it myself and went through the process. It's really good. It works really well. What you'll see, or what you may already have seen, is a lot of patients going to the app. And actually, what's quite helpful is that they can verify their own identity on the app. I think we still need to give them online access from our end, but we don't need to do the identity verification a lot of the time. Please just talk to your reception lead if you're unsure about how that works. I know that the reception leads and Gurren and Greg have been working on making sure that our flow for that is really clear and we know what's going on. In terms of remote fridge monitoring, so this is kind of not having to open the fridge. It's like a little thermometer probe that logs it to the cloud. That's been piloted and it's worked really well. So that's been ordered now for all sites. So no more manual logging, which is amazing, hopefully. And we're going to be doing an online typing course, I think, for offering an online typing course for clinical admin. And if anyone else also feels like they'd be interested or like it would be beneficial, please let Gurren know, and we can organise that for you as well. Okay, I'm going to take a pause and see if there's any questions here. So in terms of questions, so we've got a question from Rachel around Mornington. So what's happening with the building? So that building has actually been sold. So Dr. Krishna and Darshika have sold that building, and really we won't be able to use it for our service. I think it was never likely to be. It's not a particular. I don't know if anyone's been there. It's not particularly fit for purpose. It's quite an old premises, and there's lots of stairs, and it's really not a good building to have a GP practice in. Dad is working with a lot of the local councillors and property teams to try and help us to find more space. We've got a couple of places which we've got our eyes on at the moment. So hopefully we can sort something fairly soon. In terms of notes, I've got a couple of questions here. So yeah, Rachel again made a very good point around for confidential items, you can definitely mark items as confidential or specific consultations. I'm not going to go through that now because I don't really want to log into EMIS at the moment, but it's worth just doing that and making sure you're aware of how to do that. If there is something that needs to be confidential, that's important. And then Alison's asked around patient notes may create more questions. Yeah, I think this is a valid point, which is why we want to roll it out in a sort of phased way and make sure that A, it doesn't generate lots of questions, and B, I think we need to talk about this, but I don't know if we're going to necessarily text all the patients and tell them that we're going to open up their records so that we don't end up with a huge flood of people going in and checking and reading their whole record and inundating us with questions. I think it's more for as patients start to realize and maybe if they need it and they'll see it. But yeah, there is obviously at risk. Rachel's asked if she's allowed to make suggestions. Yeah, if anyone has any suggestions for new spaces or any bits of land or any buildings that look like they could do with the GP surgery or space, please just drop Dad an email. I know he's more than happy to receive them. He's given me the thumbs up in the chat, so yeah, definitely. Okay, Julie, I'm going to hand over to you. I think I can. Hang on.
Excellent. Oh, I can hear myself. Right. Ready when you are. Good afternoon to our lovely Penrose teams. I hope everybody's well on this very pleasant Tuesday afternoon. So welcome to everybody. Thank you for being here with us. This is our patient feedback update. So we're now analysing the data that we collect on our complaints, which is always interesting, really interesting to do, and it helps us to understand patterns and trends, where things are going really well and where things could do with improving, and we can look at what's going right and what's going not so right. So far in 2021, we've had 71 complaints. May was the biggest month so far, which we had 23 complaints in May. It's been crazy all across the NHS, so that was to be expected because everyone's sort of feeling it at the moment and it's going to have an impact on what our patients say, but that's not necessarily a bad thing. It is good to see this feedback coming in from patients that we can look at it, we can learn from it, and we can improve from it. And I know patients, when we respond to them, they're really glad that they're being listened to, they're being heard, and that even though we can't always do something with what they're asking, we can't change everything, they really like the fact they're being listened to. If you want to have a look at the graph on the right hand side of the screen, which gives you information about complaints over the course of the year. Again, we said that May had the biggest amount of complaints with 23. And when we've responded to those complaints, some of them people haven't responded to our response. Some patients have said thank you very much and they're very happy with the response. Others occasionally haven't been. Some people haven't liked what we've said, but we can't always change the fact they haven't liked the response, but they've at least had a response. The average day to resolve a complaint was approximately 15 days. This has sort of fluctuated, but it's dropped throughout the year, started at 21, and May and June we averaged about 8 days with responding to a complaint, which was really good. It meant we were able to investigate it quickly, speak to the people involved in the complaint, and get a resolution so that we could look at what's been happening and move on. The complaint type, the most complaint type that came in was clinical issues, but the second highest was unhelpful member of staff. And as it says here, some of those couldn't be helped. We understand listening to calls, it is the way things have been taken in the moment, but there are a fair few where we did, looking back on the situation, maybe act in a slightly disappointing or unhelpful way at the time. And we do need to try our best. It's really hard. We are only human, but we have to try our best to stay cool and calm at all times, both in person and on the phone. However difficult that can be in the situation, however hard it can be, we need to do our best to be professional and to listen and to be to understand the situation at all times, because when we want to warn a patient about their behaviour or remove them, when we've kind of given as good as we've got, it is much more difficult if we've been rude as well to be able to say, well, you were rude to our staff. We can tell them that, but then if we want to remove them, we need to have shown that we've been completely professional in our behaviour as well. The most frequent and underlying cause for complaints has been system failure, followed by chance events and things that were outside of our control, i.e. In terms of recall systems, in terms of hospitals getting in touch with us with results for things. We can't control those sides of things. And failure to follow the system. 25% of our complaints could have been avoided simply by following the systems that are in place. So if everyone can please make sure that they understand the systems, are using the post tool, know what is expected, and hopefully that can have a knock-on effect and we can avoid having the complaints. We resolved 80% of the complaints to date without patient dissatisfaction, which is brilliant, and 25 of those have seen patients actively satisfied. Obviously, we want that to rise, and it will rise, but to see that quarter's actively satisfied, very satisfying. And the next one, please, Satch. So the main areas for complaints at the moment, across the board, have been not understanding primary care capacity for urgent symptoms. I know we've had a lot of that recently, especially with children. We've had a lot of that come up. Hospital communication, appointment availability, unhelpful, rude receptionist, not understanding our multidisciplinary model. Why can't I just see a GP? Why do I have to go through a paramedic? Why do I have to speak to a pharmacist? That's something that we're looking at because that comes up a lot. Prescription review communication, if a prescription isn't prepared quickly or they need to have a review, patients get annoyed about that, or long wait for a call to be answered, all areas of recent complaints. And the next one, please, Satch. So ways that we can make improvements. I like the fact these are in green. Better communication with patients for reviews. So making sure people are given notice that they need to have a review and an explanation of why a review is necessary. It's just helpful to make sure patients understand, because just because we understand doesn't mean patients understand straight off. Keep a close eye on call waiting times, early and late, especially when we have staff holiday and sick cover, because sort of early in the morning, if you only have a couple of people answering, it can lead to a build-up of people waiting. And using post efficiently should help to speed up call times, because if you go through the post system, you are just literally following that through, and it should hopefully increase the speed of which the call is dealt with. We're also having prompt investigative meeting with receptionist and reception manager, because we've had some cases recently where things have happened over a period of time, and then when we've gone to speak to the receptionist involved, it's been so long ago that things haven't been remembered or remembered clearly. So we want to make sure that things are dealt with at the time, one, to support the people involved so that they feel that they are supported and that we're here for them, but also to make sure that things don't build up, accumulate, and we get more and more complaints of the same issue because at the time nobody looked at them properly. So we're making sure that we're looking at things quickly to have a better outcome for our team and a better outcome for our patients. More information, better explanation for patients as to why 111 or urgent, if you have urgent symptoms. Obviously the post tool will say go to the hospital or urgent care centre for urgent symptoms, But patients do feel that we're just saying it so the doctors don't have to see them, just to get them away from reception. More of an explanation as to why it's necessary, rather than just go there. Explain why that's recommended. If we need to rule out sinister causes, but we'll put together a better explanation of why that's necessary and not just fobbing them off, as some patients feel it is. Update website with information explaining multidisciplinary team. Again, why do I have to talk to a paramedic? Why do you have all these people? Why aren't you letting me speak to a doctor? Explaining why we have this team and why it's an actual benefit that we have all these amazing experienced clinicians as well as our amazing doctors, and that they're here to improve things and to speed up processes and not to hinder. Appointment availability, which should improve, because now that we're doing less double appointments, i.e. telephone and face-to-face, speaking to the patient and then bringing them in, as that changes with more face-to-face, that should hopefully help increase appointment availability, and also using the post tool more often should help with making sure that people are seeing the right person at the right time. Next one, please, Satch. So what do patients need from us? This is a general, I tend to go through this with onboarding with our new team members. That's just a quick reminder. A warm verbal handshake is really, really important. So good morning, good afternoon, the surgery you're at, who you are, how can I help? Rather than just saying morning surgery, it just helps to open up the conversation and make the patient feel that we're here for them and they're not just a burden to us. They want to be listened to. Allow them to ask their question before you attempt to answer it. Because if you let them ask it, you're more likely to understand what they're asking. So really listen to them. As when you assume, it makes an ass out of you and me. Positivity. Rather than focusing on what we can't do, appointment today, appointment tomorrow, let's concentrate on what we can do. This is what we can offer you. This is who you can speak to. And alternatives, i.e. again, the urgent care centre, 111, and the reason why we're recommending that. So make it a positive conversation and not just a, we can't do it, so we can't help you, so you have to wait 3 weeks and there's nothing we can do. Let's make it positive communication. Communication. So please try and make brief notes on a patient's record. If you've said you check something or you think it's something a colleague may have to follow on later, add something in the record to make everyone aware of that, so that if the next person speaks to the patient, you're not saying, oh, I have no idea why you're calling, or well, nothing's been left for you. It's really frustrating for you and really frustrating for the patient to feel that there's no follow-on. 5 minutes now of just making a note in a record, just a brief note, can save work for someone else and frustration and complaints later when things aren't followed through properly through the whole system. And again, follow through. If we say we're going to do something for a patient, please make sure that we do it, because it's really vital for patient practice trust. If we say we're going to call a patient back, if we say we're going to email a patient, if we say we're going to do something, please ensure that happens. And it happens as quickly as we can, rather than leaving it 3 or 4 days because we're busy, the patient's waiting. Please ensure communication is kept open. Next one, please, Satch. So current Google ratings, this is how we are all doing on Google. So we've got Penrose has 4 stars, which is brilliant. Lewisham, 4.1, which is excellent. We've got Deptford and Knights Hill slightly forward with 4.3 and 4.4. And Kingfisher currently at the top with 4.7 stars on Google. Excellent. We're all hitting more than 4 stars, which is brilliant. And this is praise from our Google reviews. Really helpful, attentive, kind staff. Caring nurses, Fatima and Elena, are mentioned on a regular basis. Professional, understanding and helpful GPs. Had 3 of those for Dr. Charlie Allen recently. Friendly, safe environment. Helps me in my preferred language, which is hugely important. Online access helps me see test results and medication. Text reminders are a big help. Apart from, I know that we've had a few recently where we've told a patient they'll be called back between this time and this time, and the text reminders giving them a wider time slot, which doesn't help. But in general, text reminders are a huge help, especially now for our branch sites. It gives the postcode of the branch sites, they know which site they need to go to, which does help in terms of appointments. Supportive service, amazing practice. And I'll go straight to the bottom. Penrose is second to none. I mean, doesn't get better than that. The majority of our patients are really happy and appreciate the hard work and dedication you all put in to giving them the best healthcare, and we all really appreciate it too. There's a lot to do. We're always looking at ways to improve, but the most important thing is that we support each other and that we're growing. But as always, from me to you, thank you, Team Penrose Health. Big round of applause. Back to you, Satch.
Take myself off mute. Thanks, Judy. That's really great. I think it's a really interesting bit of information, and I think it's always useful to get that, because we see sort of slices of the feedback and we see maybe the occasional complaint, but to see the overall view, I think, is really interesting. But obviously Julie and even Dad is helping Julie absorb a lot of that. So well done to you guys as well. Okay, so next section is going to be all fun, I promise. So social update. I'm going to start with stories from our bike ride. Some lovely pictures here. I haven't actually vetted these with anyone, so I hope they're okay. But yeah, we finally did the bike ride. It was it was pretty amazing that we actually managed to do it. I think in the end, I was not convinced that it was going to happen, but I think through sheer force of will, Garen managed to get it together. And actually we had quite a few. You can see in that picture there are quite a few of us on the bike ride, probably about 15-20 of us at least. We thought it was going to rain. We thought it was going to be another good excuse to get out of it, but it didn't even rain in the end. We put our little waterproofs on and just cracked on. So we did it was a 38-kilometer ride to Biggin Hill. Took 2 hours, I think, in total. 2 hours of cycling, I think that is. 18 kilometers an hour average, which I thought was pretty cool, and 433 meters of elevation. But most importantly, it was a lot of fun. We actually did have a lot of fun. Even I'm not a cyclist. I don't cycle regularly. Had quite a lot of fun. I started out thinking this is going to be a disaster because everyone here has the gear. They're all avid cyclists, and I have legs. That's pretty much my only qualification. But it was fine. It was great. I think best highlights for me were Dr. Sasser made some amazing brownies. They were just phenomenal. And was it Dr. Sasser or was it Dr. Rachel? I can't even remember.
Rachel's legendary brownies.
Rachel made the brownies. Oh man, it's been so long. I'm just remembering the brownies. They were amazing. Mo and Andrea had matching gear, which was my favorite. And there was a very impromptu, very technical downhill section. If you were on the cycle ride, you'd get that. It's a bit of an inside joke. And Dad had his wonderful pink backpack, which I think you can just about see in this picture, which is why I've included it. I just wanted everyone to see that. Just in case you're wondering what Dad's backpack looks like. There is a video here if anyone hasn't seen it and wants to see it. It's very good. I made it, and it's a bit of fun. But yeah, thank you to everyone who came, and thank you to Garen for organising it. Hopefully we will be doing another one soon. So yeah, and hopefully more people can join us. Other stuff that's happened recently, we've got so Greg behind me did a walk from London to Brighton for charity, which is pretty amazing. I'd highly recommend clicking on that clip, if only to on that link, if only to see a clip of Greg after the walk, not being able to walk, which is just hilarious. But yeah, it's for a good cause, and you can donate there if you'd like to. We had some donuts. I don't even remember when they were now. It was maybe a month ago or 2 months ago or something. We haven't done a town hall for ages, so I just thought I'd mention that and thank Stacey and Rafe who went and sorted those out for us and negotiated with Krispy Kreme to get our discounted donuts. So that was cool. We've had ice cream. That was when the weather was better than it is today. I've put a little collage there of some of the great photos you guys sent to me. So yeah, thank you to you guys and mainly to Alibaba really for sorting us out. And I've heard there are some competitions happening. I don't think technically we're allowed to endorse them. So you're doing them at site level, and that's fine. But yeah, good luck to everyone on that. I think my team was just knocked out yesterday, so there you go. You can tell I'm really into football. If you want to see more stuff, I'd highly recommend making sure you're on the Just for Fun channel and like just clicking on it occasionally. There's always some fun stuff in there. I won't say who posts the most, but there are some great GIFs and some great memes on there. So I'd highly recommend being on that channel. It's worth just for a little bit of a laugh. And then upcoming, we've got the Summer Social, which is going to be very exciting. Hopefully everyone has got my calendar invite. I've made a little snazzy save the date invite as well there on the right. It's 14th of August. It's going to be at the Old Elanian RFC in Dulwich. So it's basically a big field with a little covered bit as well in case the weather goes a bit awry. But essentially 12:30 p.m. 14th August. There's not really a dress code. I've put a summary on there, but you know, whatever. Just take it as you want. And yeah, we're going to try and do some food, some drink. I'm going to try and do some sports day type things, but not in like a aggressively competitive way, but more in a sort of, you know, just fun kind of, let's just do an egg and spoon race kind of thing, and maybe some face painting and stuff like that. No guarantees, but I might try and also get a bouncy castle. So if that's of interest, that might be there. I can see Judy's very interested in that from the chat. So yeah, I can't guarantee anything at the moment. We're still planning it, but hopefully that's going to be really, really fun. And so I'm really hoping that the guidelines get lifted, or that the COVID restrictions get lifted in time. And another event, 2 events in one presentation. We have got our pub quiz. I haven't actually sent the calendar invite out. I was meant to do that this morning. 9th July, so that's next Friday. We are just finalising the venue. We have a venue as a backup, but we're trying to get somewhere else as well. We have got the quizmaster. Quizmaster's been booked. Charlie's video is incoming. He's concocting as we speak. Charlie special, and that's really it. You know, Dad's going to buy a couple of rounds of drinks. That's news to him. I've just told him that in the chat live. He's given me a thumbs up, so that's good. And yeah, it should be really fun. We have to just be slightly wary that obviously the limit up until mid-July is going to be 30 people. So I think we're going to try and keep it to like 5 or 6 per site. I'm hoping that should be fine because it's Friday night and I know that people have commitments and stuff. You know, obviously we're going to be outside, so we're not going to be an indoor party, so we can do up to 30. But yeah, that should be really fun and hopefully kind of nice, relaxed evening, bit of quizzing, you know, bit of competition, and a couple of drinks. Cool. That's it on the social stuff. Town hall agenda. Last thing is general updates. So we have a lot of starters and leavers. I'm going to run through them really quickly. I think it's just because it's been 2 months and also it's been a bit mad on the hiring front. I would say that's like 50% of what I'm doing at the moment is hiring, which is great, but also tiring. So we've got Sam. I'm going in chronological order. So Sam started the others. Sam, who's our new paramedic at Knights Hill, who I hope is settling in really well. Sarah, who's one of our new GPs. She's here at Kingfisher. Charlotte, another one of our new GPs at LMC. We've got Natalie, Deanna, Chloe. Oh, I've added Chloe twice. There you go. Natalie, Deanna, Chloe, Nicole, and Nancy, who are all new receptionists at the various different sites. We've got Ruth, who's our new nurse. We've got James, who's our new pharmacy dispenser at Knights Hill. We've got Chris, who's another new GP. We've got Alex Slams, who's Alison's son, who's helping us at Knights Hill with some admin work. We've got Glenn, who started as ops support here at head office. And there's also 9 new bank vaccinators. So in addition to the old, I think there were 13 who started before, and we've had 1 drop out. So 21 in total bank vaccinators. So a lot of new starters, a lot of Bamboo paperwork. If any of you guys are on this call and I'm behind on your paperwork, deepest apologies. I am trying to do that, but there's also a lot of you, so it takes a bit of time. And then in terms of leavers, we've had a few people leave us. It's very sad. I mean, it's been 2 months, so I'm not that surprised that we've got a couple of people in here. But kind of just shout out to Andrea and Erin from Knights Hill, who have left the team. Wing, obviously long-standing GP at LMC. Marta, I know, well loved at Penrose. Jodie and Sheila from Deptford are both, or have both left. I think Sheila might be leaving, or might have just left, and Joe from LMC as well, mental health nurse. So you know, really sad to see everyone go, and hopefully you know, everyone will stay in touch, and maybe they can come back for the summer party as well. Don't know if they're interested. In terms of current hires, we've got a lead GP rollout. We've got a GP role. We've got financial controller, ops analyst, still looking for more support in the central team. Mental health nurse, we're looking for someone to cover kind of some of the holidays and also to replace Joe at LMC. And then receptionist, we're still looking for more reception cover. I think that will help with what Julie was saying around, you know, call waiting times and you know, making sure that we spend enough time with patients. Obviously, the big issue at the moment, like I said earlier, is space. So we just have to kind of be aware of that and just make sure that we're putting people in the right places. So if you're feeling like there's not enough cover and you know, we're not advertising someone, part of the reason might be just because A, I'm a bit behind, but also it might just be we don't have the space at the moment and there's no rooms available. If Goran was with us, I would show you he's got a very comprehensive spreadsheet of every desk in the group and who's on it on which day of the week and which afternoon and whatever. So we are trying to juice the maximum we can out of the space. And then in terms of other stuff that we haven't mentioned in detail, we talked about a lot, but the referrals program's been going really well. I think I talked about that last time. Thank you to everyone who's participated in that and reposted the jobs. It is really helpful. It just gets the word out there, and I think it has helped to drive a lot of applicant flow. I know certainly for the clinical roles, I've seen candidates who have come specifically from reposts, and even for reception, I've seen it come through. So if you are interested in that, I just processed payroll earlier this month, and I know that there were a lot of referrals bonuses going into payroll. I know it's not a ton of money, but it is actually quite good. And if someone comes from your ad, there's another bonus. So it's worth doing. I think I put the poster on Teams, but let me know if you're not sure what the program is and how to avail yourself of that. It's really helpful for me. It's helpful for you, and there's a bonus. So, yeah. Surgery logs, I think, pretty much embedded now. Hopefully everyone's really comfortable with those. Obviously, let Greg or Goran know if there are any questions. I think the workflow optimization work is pretty much done. I know that the clinical admin workload has been a little bit slower at the moment, just because obviously Bria is off on maternity at the moment. Operational data project it is being developed. So this is our operational data platform, which Greg has been building. We're trying to work with EMIS to actually get the data in at source and really bring in huge amounts of data into that platform so that we can understand the business in a lot more depth. You know, kind of like what we showed you with what Julie was doing, and I know that people have seen some of Goran's dashboards. They're really, really useful, and they just help us to understand what's going on. And you know, obviously we gather feedback from all sorts of different places, and data is just one of them. But this is something that we've been really lacking for a long time. I'm currently doing a pensions tidy up. I have been doing it for 3 months. As you can imagine, it's not the most thrilling thing to do, and it's also quite fiddly. So I'm trying to sort of push it along. Please bear with me, but thank you for that. Maddox Way's old EMIS. This is just a tiny little thing that's happening at the moment, but there may be an allocation for Penrose surgery if that happens in the next few weeks. You know, don't be surprised if a few patients turn up, a few extra patients turn up in the Penrose surgery EMIS. That's something that the CCG have asked us to do. There's a new NHS jobs, so more HR stuff. We're looking at the new NHS jobs and getting ourselves onboarded onto that. Significant events framework is something that has been on my list for a while now, but Julie and I have been working on making sure that, like with the complaints, we have a framework and essentially like a platform where we can analyze that. It all runs through our Asana, so we can extract the data and understand it through that. But yeah, it's a really good system. I mean, you guys still with no change from your end, but just FYI really. EMIS tidy up is still happening. We're working on child IMS for QOF, so QOF preparation. Obviously, QOF is coming back this year. I think we might talk about that more a little bit next month. There's a couple of different strands here, one of which is top secret, but the other of which is kind of ongoing, which is the chart. So basically, child IMS is one of the big changes in QOF. It's now it's a new domain in QOF and it's a lot more stringent. So we have to try and make sure that we get onto that. I literally have it open in my other tab. And hopefully we'll be kind of progressing with the rest of QOF as normal as we get through the next couple of months. We don't want to get to like January and then be like, oh damn, we've got to do QOF. So yeah, and that's it. That's kind of that's just like a selection of things. Obviously, there's a lot of day-to-day work that's happening, and you guys, obviously, everyone's doing a ton of work. I know things are really busy at the moment. There's a lot going on. I think the next town halls, we're going to try and aim for those dates, obviously subject to change. If you guys have got anything you want to talk about or want to hear me talk about or hear anyone talk about, you know, let me know. Let anyone know, and we can figure that out. And yeah, I think it's really just a case of thanking you guys. You know, like Judy said, everyone works really hard, and I know that there's a lot of, you guys can't see it, but Dad and Judy are applauding in the chat. It's true. I think everyone's working really hard, and I know that it's tough. The hospital's putting a lot of work back onto us. Patients are, you know, increasingly demanding. You can see that in the complaints data. You can see that. I think as we get into summer, I hope that it'll cool off. People start going on holiday, people starting to decompress. I think everyone, you know, hopefully is taking their holidays and really starting to decompress a little bit. But look, it's always a pleasure to work with all of you guys. And yeah, I think we will call it a day there. So thank you.